All right, welcome to F Journal exclusive member only content. This is F578, the right to request, refuse, discontinue treatment, and formulate advanced directives. So, table of contents, format's usually the same, which is we'll do a brief overview, go over the citation history or the citation statistics, then go through the interpretive guidelines, give you the bare minimum, what they need to say. There's a ton of redundancy in these interpretive guidelines, so we'll break it down and just give you the bare minimum, what you need to know, what the surveyors will look for, and then a bunch of examples, as many as we could find. And then we'll do a brief summary or some recommendations. So overview, this is relatively lengthy F-tag, so there's 10 pages or so in the interpretive guidelines. Again, a lot of it is redundant, repetitive stuff that they put the same thing in 2 or 3 places, so we cut all that stuff out. We're not going to repeat anything. Most of the citations, as we go through the examples, are going to be related to advanced directives. So that means either not having an advanced directive, and more likely the citation is for not having any discussion with, or a documented discussion with the resident or resident representative regarding formulating an advanced directive. And a lot of states put a huge emphasis on this, and especially the state that I used to live in, Washington State. I think they're in the top 5 for the most cited per facilities as far as the percentage of facilities in their state. So, and then the other citations that you'll see, the bunch of examples are either related to the post forms or to DNRs. And just a reminder, because I know every state has a different form of different version of post, but this one is physician orders for life-sustaining treatment. So let's get into the data, the statistics. Nationally by year, the last full year that we had before COVID was 2019. The year prior to that, it was ranked number 24, and they always check on these annual surveys, all the advanced directive stuff. So 95% of them come from annual surveys. Dropped down a little bit in 2019. Now, typically what you would see, if this surveying process worked, I mean, you should see a decrease in numbers of citations every year. Like 2008 should be like 1,400. Next year should be 1,200, 1,000, 800. And, going into the future, I mean, we should have systems set up that just eliminate these altogether. I think if you are really diligent and you're looking at all the examples that I'm giving, you can put together a checklist and you can make sure that your facility is damn near deficiency free. All these F-tag video training that I do, it's kind of like I'm giving you the answers to the test. So when COVID hit, obviously it dropped down a bit. Obviously they're not doing as many annual surveys. Ranking as far as frequency stayed about the same. So still, that's a lot of citations, 1,400 or so on average between the last 2 regular years, 2018 and 2019. So this is definitely one you need to get on top of. And if you just put things in place, and I got some recommendations for you later in this video, but just get a system and a process established that everyone follows and you'll be fine. Scope and severity, not very many of them are G level or above. It looks like we got 15, 4 Gs, 10 Js, and 1 K. Let's see, 2021, it looks like even though they were not doing as many surveys and not handing out as many citations, it looks like they managed to keep the J level citations as high as they possibly could. So as far as states go, I did say Washington State, they've only got a couple hundred facilities and they gave 78, so they're probably around the 25 to 35% mark. Nothing else really jumps out at me. Maybe Missouri. So we'll see. Most cited states: Maine, Vermont, Tennessee, Alabama, Rhode Island. Most cited, there you go. Washington State, 36%, so even a little bit higher than I anticipated. Thought it would be 25 to 35, so we're sitting at 36. Idaho, Hawaii, New Mexico, and District of Columbia. So the first part of the interpretive guidelines, it goes through what exactly the resident has the right to. So they have the right to request, refuse, and discontinue treatment. You guys already knew that, but again, this is another F tag that goes over their rights to request, refuse, and discontinue treatment. So they also have the right to participate in or refuse experimental research. And they have a right to formulate an advance directive. There is a however. There is no right for the resident does not have the right to insist on medically unnecessary or inappropriate treatment or services. So the facility has a responsibility, and their responsibility is to inform and provide written information to all adult residents on their right to accept or refuse any medical or surgical treatments, and their right to formulate an advance directive. And including, and this is related to the advance directive, so in regards to the advance directive, the facility also has to inform the resident that basically they have to give them a copy of the written policy, or at least a description of the written policy. Sometimes policies can sound a little bit legal, which may not be the best way to communicate to a resident or responsible party. So the facility does have to provide a description of the facility's policy on how they're going to implement the advance directive according to that particular state, what their laws are in terms of advance directives. So a lot of this advance directive information it gets kind of legal, and there's a lot of differences between states on how advance directives are handled, and different other legal instruments used to communicate the same thing as advance directive. With that in mind, facilities are actually allowed to contract with other entities to provide information about advance directives, but that doesn't relieve the responsibility of the facility to make sure that information is provided. So basically the facility can't say, hey, we contracted with somebody else and they didn't do their job, so we shouldn't get a citation. Basically they're saying that the facility has to make sure that whoever they hire is doing a good job in terms of communicating their rights about advance directives. If the resident is an incapacitated adult, which we get a lot of those admissions in long-term care, skilled nursing. If they are incapacitated, say they have an acute illness and they're not able to understand the information you're telling them at the time of admission, well then the facility may provide advance directive information to the responsible party. But, so there's a big but, the facility must follow up and provide the resident directly when they're feeling better, when the resident is able or appropriate to receive that information. So let's say that they had kidney failure and they had a toxin buildup, which is common when your kidneys fail, and they're in they went into acute psychosis, which happens when you have toxin buildup. Then you're just, some people even have hallucinations, and they just can't really comprehend anything. So they got better, did dialysis, something like that, and they're on their way to mending, but still they're still incapacitated when they admit. And the facility, basically what they're saying, has a responsibility that when the resident is capable of understanding what you're communicating in terms of an advanced directive, the facility has to go back, follow up, circle back, whatever phrase you want to use, and communicate that directly to the resident, even though it was already communicated to the resident's responsible party. So, hope I didn't complicate that too much. So, the interpretive guidelines gives us a definition for advanced care planning. And really what they define it as is a process of communication between individuals and healthcare agents. And this process is to seek an understanding, to provide some time to reflect, to discuss, and ultimately to plan. And what are they planning for? Well, they're planning future healthcare decisions, especially in the event that the resident is unable to make their own healthcare decisions. So really that's what the advanced directive is it's actually, well, I'll wait, that's the next slide. So an advanced directive, they give a definition. So an advanced directive is written instructions such as a living will or a durable power of attorney for healthcare, as recognized under state law. Again, there's a lot of variation between states. That's why they throw that in there. It's basically written instructions for incapacitated healthcare decisions. So that should be fairly obvious. If, let's say it's you become incapacitated, well, there's written instructions that you have a legal document of written instructions that says this is what I want done. So what is a POLST? Well, POLST is a very common form. That's what we use in my home state of Washington, even though I'm in Texas now. And it's physician orders for life-sustaining treatment. I know there's some other states that have a variation on this. I think Massachusetts has something called the MOLST. Not a great acronym. Kind of sounds kind of gross, but basically a POLST is a form designed to improve patient care. It is essentially a portable medical order that outlines patients' treatment wishes for emergency personnel. So this is incredibly handy, and it is a great idea. I think it's a fantastic idea. You know, if somebody goes into cardiac arrest and say they have a very complicated living will or whatever that, you know, it's like 20 pages or something like that, and you got to read through to figure out exactly what they want. The POLST form makes it very easy to just run to the resident's medical chart and, for sake of simplification, find out if they're a DNR or a full code. That's how I've seen it used most often in the facilities I've been in, and it is incredibly helpful. But the other advantage of this is that you don't have to fill out a new POLST form every place you go. You just take it with you. It's given to you when you discharge from the facility. If you're going to the ER and they're not sure what's going on with you, they'll send the POLST form with them. So it's basically a legal instrument that is well known among all the different healthcare providers, that they don't have to go, what exactly is this? Is this legal? And they don't have to get the legal team involved. All the different elements of healthcare understand what a POLST is. And a POLST also takes your current medical condition into consideration. One thing that I do want to point out is that a POLST is not an advanced directive. So this is where some facilities, I think a fair amount of facilities, got a citation because when the resident admitted and they, filled out and completed their POLST form, the facility, whether it was social services or admissions, I believe, it's my belief anyway, that they thought that, well, they did the POLST, so that's an advanced directive. Because it is, a POLST is instructions on what to do, whether you're a full code or a DNR. But the facility still has to talk about an advanced directive, which is a little more elaborate instructions. So, if the resident doesn't want an advanced directive, you got to document all of that stuff. And we'll go over those requirements here in just a couple slides. Okay, so the interpretive guidelines has a couple definitions here that we'll kind of walk through and break down. The first one is, what exactly is experimental research? My guess is most of you know what it is, but we'll just go through it and we'll give you what the interpretive guidelines definition is. Well, basically it's any development or testing or use of any clinical treatment, such as an investigational drug or an investigational therapy, that has not been FDA approved. That's basics of what the interpretive guidelines considers an experimental research or experimental therapy or drug. Next one is they define healthcare decision making. So it is the consent or the refusal to consent or the withdrawal of consent to any healthcare at all, including treatments or services or procedures that are aimed to treat an individual's physical or mental condition. And the last one is regarding the decision-making capacity. So healthcare decision-making capacity is about possessing the ability defined by state law. So this is going to vary from state to state, and you'll want to know your own state's laws, to make your own decisions about healthcare and treatment choices or decisions. So again, I mean, you guys know exactly what these definitions are, but the interpretive guideline goes through it, so it's worth putting in these videos just so you know exactly what the interpretive guideline says. So that was the last little bit of the interpretive guidelines part, where they just go through what the requirements are, and then they jump into giving the surveyor guidance, which is, you know, obviously helpful to us. But what the surveyors are going to look for is the resident's refusal of care does not absolve the facility of providing other care, such as preventative measures, and we'll give you some examples of that later on. And in fact, the resident's refusal of care still requires the facility to attempt to attain or maintain the highest practicable physical, mental, and psychosocial well-being of the resident. So, for example, this is, for example, in terms of the resident's refusal, not absolving the facility of their responsibility. So, for example, let's say that you have a resident that has refused food and fluids. They are nearing death. Well, the facility still must provide pressure injury prevention, right? You're not going to, just because they're refusing that and they're looking forward to death, so to speak, you still can't make their time on this earth even worse by not doing anything to prevent pressure injury. Let's say that also that a resident refuses artificial nutrition. They even refuse hydration via IVs, and they're having significant weight loss, which is not uncommon in the end-of-life process. Well, the facility cannot treat against the resident's wishes. So I know this is problematic because when all of this is happening, surveyors want to come in and say you're not providing appropriate care. And so a lot of times I've seen facilities that try to transfer someone out to another facility. But the fact is that the resident cannot be transferred and they cannot be discharged for refusal of treatments. Now there is a little bit of a caveat, unless the criteria for transfer and discharge are otherwise met. Okay, some more surveyor guidance. So staff must determine the refusal cause. So why are they refusing care? Is the resident unable to verbalize, can't really communicate? So maybe staff think that they're refusing when it's just Maybe they want it done a little bit differently, but they can't verbalize or communicate. So maybe it's because of pain. The pain is just so overwhelming they don't have any desire to eat. I know oftentimes in like pancreatic cancer or something like that, eating is incredibly painful enough. So maybe that is it. Or it could be fear of staph. Not unheard of. So in regards of care planning, the surveyors, what they are going to look for is that all of these services and cares that should be provided to the resident, even though the resident is refusing, all of these services and cares need to be put in the care plan, and then it just needs to be documented that the resident is refusing those. So even though they're refusing them, like in normal circumstances, like if a resident refuses a particular medication, all the time, they just don't feel they need it, you'll often discontinue it. So in this sort of instance, you want to keep it in the care plan and just document the refusals. So the interpretive guidelines also gives us some surveyor guidance on experimental research. So if the resident is considering experimental research, has the resident and or responsible party been fully informed of the nature of the research, and have they been informed of their risks and benefits? So the resident must provide informed consent to the facility prior to the initiation of any treatment. This is true of pretty much everything, but especially true with experimental research. So if the resident is incapable of providing consent, well, then the facility must ensure that consent has been obtained from the resident representative and that it has been properly obtained. So what that means is, let's say that the resident had delegated some authority, or maybe it was appointed by the court in the case of a guardianship or something like that. Well, did the resident or did the court actually give the responsible party the authority to make that decision to, let's say, enroll them in some sort of experimental research trial? So it needs to be properly obtained. And also the facility has a responsibility to have measures in place to protect the resident from any harm or mistreatment. A lot of different ways I can explain this, but let's say that family, part of the grieving process is they would do anything. I mean, a lot of people burn through literally their entire life savings to prevent from losing a family member, which is very understandable. But sometimes it is like misplaced hope, and so oftentimes experimental research may not be even effective, but families are kind of grasping at straws, just hoping for a miracle, so to speak. So there needs to be, the facility has to step in if it appears like they would need to prevent any harm or mistreatment, even if that mistreatment was unintentional. So the facility has that responsibility. So the resident and or resident representative must be afforded the opportunity to refuse participation both before and during any experimental research. And to me, that seems obvious. Okay, some surveyor guidelines regarding end of life, and this kind of plays into the advanced directives element of this FTAG. Really what they're looking for is making sure that the end of life process is as painless and has as little stress as possible. So one thing that they've identified as far as the end of life process is that one of the key elements to end of life quality care is the ability to control your decisions. So one of the ways that obviously you do that, especially as your condition gets worse and worse and you have ability to make decisions, I guess you could say, to a lessening degree, especially if you become incapacitated and you can't make decisions. This is where advanced care planning really comes in. Having an advanced directive really allows someone incapacitated to have their wishes carried out. So that's how this end-of-life surveyor guideline is included in this FTAG. So what they say, what the interpretive guidelines tells the surveyors to look for is to make sure that there has been some advanced care planning done, that it is ongoing, and that there are opportunities or I guess every so often a reassessment of the care planning. Advanced care planning needs to be done, especially as conditions change. And again, when you reassess the care plan, it needs to be done both routinely and as you have a change of condition. So if something significant does happen, and it can go either way. I mean, I've had several residents that were on hospice, and their family and everybody thought that they had one foot in the grave, so to speak, and they had a miraculous rebound, and their condition dramatically improved, and so they had to reassess the care planning. And then all of a sudden they're like, well, hey, the doctors were taking another look at it and go, I think we have an opportunity to really kind of turn this thing around. The doctors were kind of stunned in both cases. They were kind of like, I didn't expect this. This is amazing. So as conditions change, it needs to be reassessed both routinely and any change in condition. So the surveyor guidance for policies and procedures is they're going to look at the policy and procedures in the sort of the light of the facility that having the responsibility to establish, implement, maintain, and ensure that the staff follow all of the policy and procedures related to the advanced directives, right? So whatever their wishes are, whatever the policies are, the surveyors are going to go and look and make sure that the policies and procedures for carrying out a resident's wishes, especially if they have an advanced directive, if those wishes were carried out according to policies and procedures. Again, this is another one that seems very obvious, but that's the guidance they gave the surveyors. Okay, so some more surveyor guidance, and this is really what the surveyors are going to look for in terms of looking at the facility's policies and procedures to achieve the goals of this FTAG. So as far as advanced directives, the first thing that they're going to look at is, well, did the resident or does the resident have an advanced directive? If they do, well, then all is good. Not a whole lot of places to go if they have an advanced directive, and really that's the push for states and for having this big push for having an advanced directive, is it makes all health care decisions much easier, and it's much less likely to have any sort of lawsuit if they do have an advanced directive, because it's very clear and not a whole lot of wiggle room. So if they don't have an advanced directive, did the resident wish to formulate an advanced directive? If there's no documentation on whether they didn't want an advanced directive or not, or even if there was no documentation that it was discussed, an advanced directive was discussed, they're going to go ask the resident and going to say, hey, did you want to do an advanced directive? The PULST is not an advanced directive. That is gives just the basic information, but we can go much more detail with an advanced directive. So they're going to determine that. They're going to try to determine if the facility provided information about an advanced directive, written information, that was in a proper form and format. That's a common theme throughout all these FTAGs, is you got to give it in a form and format, language, that the resident and responsible party can understand. It needs to be clear and understandable. So if you have to have a translator, then you got to do that one. And then they're going to find out if the facility informed the resident and responsible party about their right to refuse treatments and to formulate an advance directive. I mean, all this seems very obvious. Of course you have a right to formulate an advance directive, but the interpretive guidelines and CMS regulations require the facility to inform the resident and responsible party that they have a right to formulate an advance directive. And as we've been going through all these resident rights, FTAGs, it should be becoming very clear that there's a ton of information we have to inform them on. The residents and responsible parties on it's usually taken care of in the admission packet. But so then the surveyors are going to go and look at the policies in regards to advance directives. A little bit of overlap with the just the last bullet points that we talked about. And as far as advance directive policies, they're going to make sure that you have a written description. And obviously policies are going to be written, but they want to make sure that you have a description of the facility policy about how the facility will implement the advance directive. And this is pretty basic, and I would suggest that any of you watching this video write down a note and say, hey, I'm going to go look at what our advance directive policy actually is after the video. And the reason that there's differences with policies with advance directive, why there's not just one clear-cut policy for every facility, is that there is a lot of variation in state law regarding advance directives. The federal government, the CMS, does allow for quite a bit of differences in how states determine how they're going to treat advance directives. So you'll want to understand obviously your state. If you're a regional or something like that, you're definitely, and you got more than one state, you're obviously going to want to understand all states that you're responsible for. The surveyor is then going to determine if the facility periodically reassessed the resident for decision-making capacity, and if they were lacking, if there was any evidence that the resident was lacking decision-making capacity, they're going to determine if the facility invoked a healthcare agent or a responsible party to assist in the decision-making process. If they are lacking capacity, what should have been done is that the primary decision maker should have been identified. This is always a good thing to do well before any resident is incapacitated, but let's say that the resident is admitted to your facility and he is already incapacitated and cannot make decisions for himself, does not have an advance directive. Well, then you need to identify who the primary decision maker is going to be for that resident. They do not have one. Say there's somebody that's homeless and they don't have any family or anything like that, then the facility does need to attempt to make efforts to get them a guardian, conservatorship, or whatever it may be. The facility cannot be the primary decision maker for a resident in that facility. Next thing they're going to see if the facility accomplished was if they are explaining and clarifying any of the healthcare issues to the resident and or resident's responsible party, the healthcare agent. And they're going to determine if the care plan was reviewed and if care instructions were properly communicated to the resident and the responsible party. They're going to look at communication between the facility and resident or responsible party. They're going to see if there was communication between them to identify situations where healthcare decisions may be needed by the healthcare agent or responsible party. They're going to look to see if the facility documented what the communication was between the facility and the resident or responsible party and what those choices were. And they're also going to they're going to see if the facility identified situations where care cannot be provided by staff. So this goes back to one of the other slides where we talked about the resident's right to refuse, or the responsible party on behalf of the resident has the right to refuse treatments, but it all still needs to be care planned, and it just needs to be documented that while it is in the care plan, and this is care that we should be giving, the resident is refusing. So it's best to identify those situations where the resident refuses. So for instance, if somebody's dying, great deal of pain, and they're not eating anymore, identify that situation and put it in the care plan that the resident refuses to eat and staff has been unable to assist them with feeding. They've made attempts and continue to make attempts to feed the resident, but they continue to refuse. So this is a very busy slide. I may come back at a later time and sort of redo this one and try to make it a little more clear if I get some feedback from you guys that this slide was too busy and too complicated or anything like that. Please, if that's the way you feel on any of these slides, or if you think I do a poor job explaining any of these slides, please put it in the notes. I'm just here to make sure that, I'm here in an attempt to make the interpretive guidelines simpler, easier, and certainly much quicker than reading a 700 or 1200 page book, whatever format that you look at. So okay, so some more information on advanced directives and what the surveyors are going to look for. So there's a lot of overlap, a lot of repetition, a lot of redundancy in this interpretive guidelines. Again, this one could have been made about 60-70% as long as it actually is. So, but we'll go through it. So the surveyors are going to determine if an advanced directive was executed. They're going to see if it was prior to admission or upon admission, and they're going to verify and make sure that copies have been obtained, because copies must be obtained, and maintained in the resident's medical record. There it is, medical record. Another thing they're going to look at is they're going to make sure that the advanced directive is accessible and retrievable by any facility staff. So the whole point of this is what they're trying to prevent, and I've seen this in some of the citations that people get or even facilities I've been at, is that, let's say that somebody goes into cardiac arrest and they don't have their pulse form or their advanced directive accessible to staff, and so they don't, let's say you're in a huge facility, you can't memorize absolutely everybody's code status, right? You don't know if the full code, DNR, if they're okay with CPR, but not, being intubated or anything like that. So it needs to be accessible to staff. And really the pulse form, or any variation of the pulse form in your state, is it's a requirement to have one when you come in, even if you don't have a advanced directive. But that's your best bet in an emergency. So it does need to be accessible by any facility staff. And then after that, the facility staff must communicate the advanced directive wishes, resident wishes, to the direct care staff and the physician. So really just kind of this little flow chart is really just trying to understand from start to finish how the facility is implementing the wishes of the resident's advanced directive. So first you got to figure out if they have one, when was it done, are copies on record, is it accessible by staff, and if it is staff communicating the resident's wishes to the people actually on the floor taking care of the resident, who would be doing CPR and everything like that, as well as the resident's physician, who was going to make medical decisions for the resident, so on behalf of the resident. So the facility must inform the resident. This is more of another slide, and this is in the event that the resident does not have an advanced directive. So the first thing, and this is going to sound repetitive, the staff must inform the resident responsible party of their right to establish one. Staff must document the discussions in the medical record. So the facility must inform the resident of, and this is going to sound redundant, but hey, the interpretive guidelines is awfully redundant. So as I go through it, just try to give you the information they're presenting. A lot of it sounds very familiar, but there are some nuances to it. And this is this slide is really looking at the approach from what the surveyors are going to look for. So they're going to look, so if the resident has no advance directive, they're going to look to see if the staff inform the resident responsible party of the right to establish one. They're going to do so with the state law, applicable state laws in mind. And if the resident has any documented evidence that they wish to formulate an advance directive, or on the other side of the coin is if there is nothing in the documentation that says that they did not want to formulate an advance directive, then the surveyor is going to go ask the resident or responsible party if they wish to. And if the resident says, yes, I want to do an advance directive, and the facility did nothing to help them, well, then you're going to get cited. So the facility must provide assistance if the resident or responsible party wishes to formulate an advance directive. And of course, staff must document all the discussions in a medical record. So some more surveyor guidance. The resident obviously has the right to execute an advance directive, but the resident cannot be required to do so. It would be nice. It makes everything easier if everyone had an advance directive, all the residents, because then you have their healthcare decisions cut and dry. There's not a whole lot of wiggle room or a whole lot of debate on what exactly their wishes are because they have it all written out. So the facility staff are not required to provide care conflicting with the advance directive. So if the resident has an advance directive saying they do not want to be intubated or forced any sort of medical treatments on them, facility staff cannot be required to provide care. Again, seems obvious. Also, facility staff are not required to provide care as a conscientious objector if allowable by state law. So if you don't know what your state law is, find out what your state's views are on conscientious objectors. I'm not going to go into that too much, but know your state, especially if you're somebody that has very, I don't want to say rigid, but if you have very strong convictions, whether it's religious or whatever, and you think this might be a problem, then look into it. You do have the right to not provide care if it goes against possibly your faith or something like that. So if that's important to you, certainly look into that. I would imagine every administrator and director of nursing would support you in that. I'm sure there's other staff on hand that could do some of the work that you object to. So some more surveyor guidance. What are they going to do? Well, they always observe. And they're going to observe the effort by staff to inform the resident of the rights. Again, this is taken care of in the admissions packet, and as I suggested in some of the other F tags, if you inform them of the rights at the resident council meeting every month, go over it, take 5-10 minutes, and then do it at every quarterly care conference, you should be covered, and document the heck out of it. And they're also going to observe if the information was communicated at useful times. So sometimes, right upon a mission when they're still feeling like hell, it's not the best time to talk about, what do you want to do if you die? If they just had a stroke or something like that, you do have to bring it up in the beginning, but you don't have to put a huge focus on it. So, again, if they're not receptive to having that discussion, then document that you asked them, would you like to discuss this at a later time, and then certainly document their response. So then the surveyor is going to do some interviews like they always do, and they're going to find out if the resident or responsible party was informed in an understandable manner. Again, that's the form and format. They're going to find out if the staff is aware if a resident has an advance directive and what those wishes are. You can't expect all the staff to know exactly what the code status is of every single resident, especially if you're in a huge facility. Really, the key is that if something does happen, they know where to access it and they can get to it quickly, especially if they go into cardiac arrest or something like that. They're going to interview and they're going to find out if the resident does not have an advance directive. How was resident informed of his right to formulate an advance directive, and it was assistance provided. Again, this is all repetitive. I'll watch this video after I'm done filming it, and I'll see if I can take out some of these slides and make it shorter. And the last one was the resident assessed for decision-making capacity. At what frequency, how were they reassessed, and who was the assessment done by? So surveyor guidance on this is more on record review, and so does the resident have an advance directive and a copy in the chart, and does the facility have a policy and procedure to implement the advance directives? So some elements of non-compliance. This is going to be obvious to you, but this is actually in the interpretive guidelines. It's like 6 or 7 pages for this particular citation. So they're going to be the facility will be in non-compliance if they fail to provide appropriate information at the appropriate time. If the surveyor has failed to find a copy of the advance directive in the chart, and if they fail to find policy and procedures about how the facility will implement the wishes of the advance directive. The facility will be in non-compliance if the facility failed to honor the resident or responsible party's decision to request, refuse, or discontinue experimental treatments. And the facility will be in non-compliance if the staff failed to follow their policy and procedure for implementing advance directives according to any state law regarding advance directives. So some cross-tagging potential. Well, the first one is F571 for concerns relating to designating or designation of a resident representative, as well as F553 for concerns relating to residents' right to be informed and to participate in their own care planning. Honestly, there's more cross-tagging potential, but those were just the two that were mentioned in the interpretive guidelines. So, some actual citations, and this is really, in my estimation, this is really the value of going through all of these videos, is really seeing, because there's a huge gap between the interpretive guidelines and then what they actually write the citations on. They give you a pretty good framework, but when you start seeing what the actual citations were, it really clarifies it up for you. So the first one is no documented offer anyway, to formulate an advance directive. There was no current copy of an advance directive in the medical chart. There was no written info given to the resident or responsible party on advance directives. No signature on a DNR form, so that could have been a POLST or MOLST or whatever it may be, which is actually the next one, which is no MD signature, no physician signature on POLST. Let's see, the DNR was not signed by the durable power of attorney, the DNR was signed by the durable power of attorney, but the resident was not incompetent. No evidence resident was given a copy of resident rights. There was no annual review of code status. That should be done every quarterly, at every quarterly care conference. Review their code status. Take 10 minutes before you get into the updating them on their care plan and everything like that, or discussing that, and just go over the resident rights and a lot of the code status stuff. Unsigned and outdated MOLST. Again, I think that's the Massachusetts version of POLST. Incomplete advance directive. No evidence that an advance directive was discussed. No advance directive discussed at admission. So the one before that was even at quarterly care conferences, the advance directive still wasn't discussed. Code status only on MAR, not in chart, and it was not accessible to all staff. Code status locked in medical records. You can, when I mentioned that other slide, I told you that the code status advance directive was not accessible to the staff. So if somebody does go into cardiac arrest, I mean, how are they supposed to figure out? I mean, imagine somebody's like on the floor, cardiac arrest. You got to run down the hall. You log in. You got to go through, find the resident. Then you got to go through the care plan and find out. And I mean, it'll literally take you 4 or 5 minutes, especially if you're not exactly sure where to find where their code status is in the little wall kiosks that the CNAs or nurses use. So expired pulse form and chart, incorrect code status and chart. That's oops. No admit packet given to resident, listed POA, but there were no legal documents proving that the person actually was POA status. Conflicting code status, hard chart versus MAR. Missing pulse form. Resident expressed code status to surveyor that was different than what was documented in the chart. That's why you review it quarterly. Several residents expressed not being offered assistance with formulating an advance directive. Advance directive wording not acceptable to Michigan standards. Son's signature on advance directive, however, the resident was not incapacitated. So here's where we get into some of the G-level citations. This is a big one. CPR initiated, but the resident was a DNR. Next one, resident was found unresponsive. They did not call emergency medical services. They had no pulse, not breathing, unresponsive, and they didn't call 911. No legal surrogate established for resident on hospice, and the resident was cognitively impaired. So in this case, the facility was making healthcare decisions for the resident, which is a bit of a conflict of interest. So you want to make sure that anybody that is incapacitated or cognitively impairs has someone speaking for them besides the facility. Nurse inserted catheter despite the resident's refusal. Again, that goes back to the resident's right to refuse treatment. Facility did not complete court-required paperwork for continued treatment as requested by responsible party. Looks like we got about 5 J-level scope and severity citations to wrap it up here. Staff hid medications in food and resident was unaware he was taking medications. So again, this is a violation of the resident's right to refuse medications or treatments. EMS was called and they initiated CPR. However, the resident was DNR. Resident found unresponsive. EMS called, but no CPR initiated. So a little nuance there. So they did call EMS, but in the meantime, no one started CPR. And so by the time EMS got there, you know, the resident had gone long enough without air and the resident passed away. Inaccurate pulse, and there was no durable power of attorney paperwork on file. And this one, CPR was given and the resident was a DNR. So a lot of these, you know, well, I shouldn't say a lot. I said a couple of these are exactly the same, and the reason that I put them in there is I wanted to sort of shine a spotlight on the fact that something that is an F-level citation can also be a G or a J. A lot of it is based on whether the surveyor feels like actual harm was done or if there's more of a systemic problem with the event at hand. So if CPR was given and the resident was a DNR, well, is that because advanced directives and pulse forms are not accessible to all the staff? So in that case, if that's a problem, then it'd be certainly more of a systemic problem, a systems problem. So Anyway, I just wanted to include those so you can see that sometimes an F level citation can easily turn into a G or even a J. So